Welcome to this Continuing Medical Education Internet Symposium. This independent CME activity is jointly provided by the Postgraduate Institute for Medicine and Viral Ed Inc. Support for this program has been provided by an independent educational grant from Gilead Sciences Medical Affairs. This independent CME Internet Symposium, entitled ARV Therapies and Therapeutic Strategies, CROI 2017 Expert Review, is being brought to you from Seattle, Washington, and will discuss new studies on ARV therapies and therapeutic strategies presented during CROI 2017. This program is produced by the Postgraduate Institute for Medicine and Viral Ed Inc. It is not a session created by or presented at CROI 2017, and it is not sanctioned by the organizers of CROI 2017. After completing this activity, the participant should be able to use data reported at CROI 2017 for counseling, testing, and antiretroviral treatment to prevent HIV infection, especially in underserved communities. Use in a clinical setting findings from key studies on HIV/AIDS diagnosis, management, and treatment presented at CROI 2017. Employ strategies based on studies and data presented at CROI 2017 for helping HIV-positive patients in medically underserved communities link to and stay in appropriate and effective HIV care. Discuss with patients and colleagues the studies and data on therapies for HIV/AIDS presented at CROI 2017 and use that discussion to decide on appropriate planning of therapy for patients with HIV/AIDS. Our distinguished faculty for this program includes Drs. Ian Frank from the University of Pennsylvania in Philadelphia, Pennsylvania, Jürgen Rockstroh from the University of Bonn in Bonn, Germany, Jose Arribas from the Hospital de la Paz in Madrid, Spain, Graham Moyle from Chelsea and Westminster Hospital in London, England, and Renslow Shearer from the University of Chicago. The Postgraduate Institute for Medicine requires all faculty participating in this activity to disclose any real or apparent conflict of interest they may have as related to the content of this activity. All faculty disclosures can be reviewed here or on the homepage of this program. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education, ACCME, through the joint providership of Postgraduate Institute for Medicine and Viral Ed Inc. The Postgraduate Institute for Medicine is accredited by the ACCME to provide continuing medical education for physicians. Please refer to the current slide or program website for information on the specific amount of AMA PRA Category 1 credits offered for this activity. Physicians should only claim credit commensurate with the extent of their participation in the activity. Thank you for your time. The program will now begin.
Hi, everybody. Welcome to today's program. I'm Ian Frank. Joining me today on the couch are Jose Arribas, Graham Moyle, and Jürgen Rockstroh. We're going to share with you some of our perspectives and the highlights from the Conference on Retroviruses and Opportunistic Infections from Seattle that was recently completed. I'm going to start by talking about some of the hot topics with a focus on prevention and cure research. So let's start by looking at some of the data from the Centers for Disease Control. This gives us the most recent data on the U.S. epidemic. And I'm sorry for taking this nationalistic approach to start the conference, but I think when you guys pay your NATO bills, we'll talk about the international epidemic. So the news is good in the United States. Looking at the epidemic overall, there's been a decline in the number of new cases of people living with HIV. But as you can see, there's no decline in the epidemic among men who have sex with men. The decline is mostly in individuals whose risk factors are intravenous drug use, heterosexual contact. And if we look at incidence by age, we see that the epidemic is declining in the adolescent category, but it's going up among MSM ages 25 to 34.
But since these figures really only go to 2014, the question is that still true in 2017 where PrEP has now a much bigger use in the United States, right? I mean, do you think that's really the true picture, or is this already changing, considering that there are reports from studies with a larger PrEP rollout showing declines in new infections among MSM?
Well, I think we have to wait and see. There are reports of declining incidence rates in MSM in some cities, but not in others. We'll talk about PrEP, and we'll talk about who's utilizing PrEP. There's about 80,000 people who've started PrEP in the United States so far, but among the people at highest risk, unfortunately, those people are often the folks not starting on PrEP.
So this same pattern is happening in Spain. The epidemic is maintained right now by young MSMs. It's the same.
Okay. So there's also some racial disparities among incident HIV infection. The epidemic among blacks in the United States is relatively level. Among whites, there's been a decline in incidence rates, but actually it's the Latino population that is experiencing a continued increase in new infection rates. If we look at the people who are on antiretroviral therapy who have durable suppression, again, this is data from the CDC, and they looked at the viral loads that are reported from 33 states or jurisdictions that the CDC tracks. And among the 631,000 individuals, 32% had no viral load in 2014. So that means that they have either not been linked to care or not been retained in care. And about 14% only had one viral load. So those people also may not be effectively retained in care. But you can see that, again, looking at the entire population, it's about 40 to 50% rates of durable suppression. Relatively similar rates among men and women with HIV infection, but racial disparities, which we've seen in the United States really since the beginning of the epidemic. Lower rates of virologic suppression among blacks compared to Hispanics and whites. A little bit of difference in virologic suppression rates among MSM, doing better than individuals with intravenous drug use. There's a clear correlation between age and virologic suppression rates. The older you are, the higher the rate of virologic suppression. Younger folks doing less well. Interestingly, the people who are more recently introduced into care have a slightly lower rate of virologic suppression than people who have been on care for a longer period of time.
Do you have any idea how this pans out by insurance status, whether it's managed care, affordable care, or ADAP public care?
Generally, the people who are less well insured are less likely to have virologic suppression rates. I don't know how the Affordable Care Act in the United States has helped people access care more effectively. HIV is somewhat of a carve-out illness in the United States, so there's been the AIDS drug assistance programs for individuals who have traditionally fallen into the gap, making a little bit too much money to qualify for medical assistance programs. And so most people with HIV have been able to access medications.
So these numbers show that you're really far away from the 90-90-90, right?
Yes. These numbers should be about 72 or 73% based upon the 90-90-90 treatment paradigm. We do a great job in the United States from the CDC perspective. Less than 15% of individuals with HIV in the United States are undiagnosed. So we're doing a lot better, although the highest rate of undiagnosed HIV infection is among the youngest MSM, where only about half of that particular population are aware of their HIV infection. So we still have a long way to go. I think, though, in linking and retaining people into care, that's where we really fall. And give us, your perspectives, because European countries are really doing among the best, right?
The UK was reported as being the best in the world, along with Australia and Switzerland at the World AIDS Conference. And that's been in part also because we have a relatively targetable population, either urban MSMs or people who have come from high prevalence countries. And in recent times, there's been a drop off in the number of new infections because people are buying their own PrEP. So even if they recognize they're at risk and they can't get it from a doctor, people are buying it.
Oftentimes we see data like this, and this is data from the HOPS cohort, so 9 clinics in the United States. And the perception is that we're doing really well in the United States, with over 90% of individuals in the most recent years on antiretroviral therapy, and the time individuals have a viral load of greater than 1,500 copies. And that number was selected because from the original CROI study, if a viral load was less than 1,500 copies, you didn't transmit your HIV infection. So that's why they were looking at this particular number. And you could see the proportion of individuals with a viral load greater than 1,500 in either the blue or green line, they sort of coalesce in the recent years, is less than 10%. So the impression is that people in the US have undetectable viral loads, but the reality is that there's a large portion of the infected population that is not being captured in this because they're not being linked or retained in care. Internationally, there was some evidence that we're really getting ahead of the epidemic. So this is data from Uganda, the Rakai district in Uganda. And in about 2006, they had a very aggressive HIV prevention program that rolled out. 2 parts. One, treatment as prevention, so trying to get a lot of people on antiretroviral therapy, even people with higher CD4 counts, and then a very aggressive male circumcision program. So in 2006, approximately 15% of the male population was circumcised, and that increased to about 60% in 2016. And you can see the impact that treatment as prevention and male circumcision have played on the incidence rates. In 2006, the incident rate was about 1.16 infections per 100 person years of observation. And that's declined by about 40% to about 0.7 infections per 100 person years of observation. So dramatic improvements, with treatment as prevention and other programs to try to.
I think it's important to highlight that this whole concept of treatment for prevention works very well in countries with a high prevalence, and I think works less well in countries like Germany, where the overall prevalence of HIV is so low that it just doesn't have an impact, and you really would need to treat 95% of the population to have an impact by the treatment as prevention. And it's different in the African countries with very high burden of HIV disease. But it's really reassuring to see how many African countries have responded and where you actually see something similar. So I think it's great that there are also African countries which already have achieved the 90-90 goals. And I think that's, one of the biggest accomplishments in HIV therapy.
Although some epidemiologists, I think, argue the opposite, that if there is a lot of sexual concurrency, and if the treatment as prevention strategies are relatively low, then you still may have a lot of transmissions that occur. So I think you may need to have a very high capture rate for treatment as prevention strategies to work very effectively. One epidemic that we don't talk about in the United States very much, but has a big impact on HIV transmission, is substance abuse. And there was data, again, from the Centers for Disease Control looking at their national HIV behavioral surveillance data that demonstrated quite clearly that we have not had any kind of impact on the proportion of MSM who use opioids, methamphetamine, or cocaine. And in fact, there are changes in how different segments of the community use drugs, with an increase of methamphetamine use among blacks and a decrease among whites. And there's some data that was that clearly showed this from Washington, D.C. So I think that this is a major issue that we need to tackle, because it's this population, I think, that's really responsible for a lot of new cases
and it's
among
the
men who have sex
patient
with men.
population, which also is obviously struck by the outbreak of acute hepatitis C, and there was a lot of work here at the conference, reporting that the use of crystal meth in particular was associated with an increased risk for getting hepatitis C, and I think that is an ongoing problem in Europe. The amount of people using amphetamines is really increasing quite dramatically, and unfortunately that really comes with a lot of new STDs, and so that's really something to tackle. And the messages for IV drug users just doesn't translate into that MSM population, so I think it really needs a new campaign and awareness to tackle the issues of substance abuse in MSM.
You probably saw that in San Diego there was also reported a lot of transmission similar to rates in Europe, so it's happening in the United States as well now.
There was an interesting presentation from the Seattle group here that looked at PrEP utilization among MSM who use methamphetamine. And 93% of the population surveyed, was over 200 individuals, were aware of PrEP, knew where to go to get it, but only 7% were utilizing it. Yeah. So I think that we really need to come up with new strategies for this particular population. So I want to talk about biomedical prevention for a moment. We heard at the IAS conference some data looking at vaginal dysbiosis and how that can influence HIV acquisition rates among women. And there was some data that suggested at that time, which was confirmed in vitro, that Gardnerella had an ability to break down tenofovir levels, and there was some suggestion that women who had Gardnerella predominant vaginal microbiomes were more likely to become HIV infected, perhaps for that reason. So there was data from the microbicide transmission network that administered vaginal tenofovir to women over a 6-day period of time, and then assessed the concentration of tenofovir in the vagina, and they showed, as is demonstrated on the slide on the left, that the higher the prevalence of Gardnerella, the lower the tenofovir levels. They also administered tenofovir vaginally, and then 2 hours later did a cervical biopsy, and they were able to demonstrate that women, again with a higher prevalence of Gardnerella in the vagina, had a decrease of tenofovir in cervical tissue after just receiving tenofovir 2 hours previously. So
I think the unanswered question is, if you treat their bacterial vaginosis, does this then result in an improvement in the tenofovir levels? Because that's really the proof that it's actually the Gardnerella, that you want to remove the Gardnerella and see if the levels rise.
Right. There was some data to show that it was not related to pH, though. So it's it's not a pH-dependent phenomenon. But yes, I think we have to see if we can alter the microbiome and have a differential effect. The good news is that oral tenofovir still works. So this is data from one of the oral tenofovir prevention studies that show that irrespective of the level of vaginal dysbiosis, there was a similar rate of HIV prevention in women who were taking oral tenofovir. You can see on the slide, though, that women who have intermediate or higher rates of vaginal dysbiosis, though, are more likely to become HIV infected, probably because of higher rates of immune activation in that environment. So there was some data that was presented from Atlanta among young men who have sex with men, and there were awareness and uptake of PrEP. So this was a very aggressive PrEP awareness program. Individuals were shown videos and then asked if they were interested in taking PrEP. Everybody had either insurance or they were provided PrEP if interested through the pharmaceutical sponsored compassionate access programs. Individuals didn't have to pay for any medical services or laboratory tests. And you can see among 184 individuals who were eligible for PrEP, 10% right away said that they weren't interested. 27% said, well, I'd be happy to discuss it maybe at my next appointment. So of the 63% who were interested in initiating, over half didn't attend their initiation visit, and 46% initiated PrEP, and then only 83% are currently on PrEP. So it's about a quarter of the population eligible who ended up following through.
But this kind of retention in care is an issue in infected people as well. And it's a matter of that test and treat data that was at the World AIDS Conference that said, actually, if people walk out the door at the visit with a pill, they'll come back and they'll keep taking the pill. And maybe that's the opportunity with PrEP, is that you need to say, we're not just having a talk about it, here, have some to try, and then come back in 2 weeks and see how you've gone. And they're more likely to finish up on it than having a later appointment for an initiation
Yeah,
visit.
that's a good point. Create the sense of urgency. This is something that you need to do, and you need to do it right now. So a little bit of data on some of the longer-acting products. There was some data from the HPTN looking at long-acting rilpivirine. There was a 4-week oral lead-in phase followed by injections of long-acting rilpivirine every 2 months, and you can see that individuals maintained steady-state concentration that exceeded the IC90 of HIV for rilpivirine. And there was a lot of acceptability to this. It was only about 5% of individuals who said that they wouldn't use this. And most said they would probably or definitely use it. For women, women wanted a contraceptive to be incorporated into the injection. And there was some data showing that internationally, women in particular prefer an injectable PrEP strategy rather than an oral or a topical PrEP.
Just as a reminder, when we did the original PK study with that at our site, we did have one person in the lowest dosing group who acquired HIV during the course of what was a pharmacokinetic study, despite advice to practice safe sex and so forth. So clearly there is a threshold where rilpivirine doesn't work, and we don't necessarily know where that level is at the present time. So just because they reach an IC95 equivalent doesn't necessarily mean that's a protective exposure.
And there was a case presented of an individual who got HIV while taking oral tenofovir FTC with what should have been protected concentrations. So along these lines, warnings about the potential for resistance. There was an animal model that looked at the consequences of getting long-acting cabotegravir administered if you had recent HIV infection. So, occasionally an individual who will be initiated on PrEP will have just acquired HIV. If a viral load test is not done, you may miss their HIV infection. And so in this model, this animal was infected with SIV, given cabotegravir, and you can see the development of integrase-resistant virus that had developed over time. So the last thing in this prevention section that I want to talk about isn't an antiretroviral, but it's antibacterial therapy on demand to prevent sexually transmitted infections. So this is data from the IPERGAY group that offered individuals doxycycline if they said they had potentially been exposed to a sexually transmitted infection. So 3 days of doxycycline after a potential exposure. And you can see that those individuals that got doxycycline as post-exposure prophylaxis were less likely to get a sexually transmitted infection than those that got a placebo.
I think this was a little bit controversial because of the issue of resistance, that you start to give that much prophylaxis, we will be able to see also resistant emerging, right?
Yeah, I think that's a potential consequence of this strategy. I think it's intriguing data.
It's intriguing.
I'm not sure it's something that we should be doing in our clinical practice.
But was that true though for all STDs? Was that also true for syphilis, right?
It was true for syphilis. It was not true for oral gonorrhea, but it was true for rectal infection.
This is the first syphilis PrEP we sort of ever had heard of, right?
Yeah.
That's good.
All right, so just to summarize some of the important points in prevention, We're getting ahead of the epidemic in some groups in the United States, but not in all. Expanded HIV treatment programs and other prevention strategies are working internationally. Oral PrEP with tenofovir FTC is going to be effective in women with vaginal dysbiosis, but the microbiome is likely to influence HIV acquisition and some PrEP strategies when topical PrEP is administered. There are some disparities in PrEP implementation, which we are wrestling with. I don't think we have very good strategies to understand how to deal with that. Long-acting PrEP is under investigation, and some intriguing data on post-exposure prophylaxis for sexually transmitted infections. So let me say a few words about cure. There's been a lot of interest in trying to treat individuals very early after HIV acquisition because very, very early treatment limits the size of the latent reservoir. And there's been a cohort that's been developed in Thailand, as well as cohorts in other parts of the world, where individuals with very early HIV, individuals with viral loads that are detectable but before antibody develops, are started on antiretroviral therapy right away. These are the FIBIG-1 class acute HIV-infected individuals.
That's amazing that they can get these patients with such an early infection.
Yeah, it takes very aggressive viral load testing programs to do this. So they had a group of individuals treated very early after HIV acquisition with no latent virus detectable in a couple of different assays. They stopped antiretroviral therapy in individuals who'd been on treatment for an average of almost 3 years, and there was a very rapid rebound in viral load. This is a little bit delayed compared to individuals who started on therapy with chronic HIV infection, but it's it's an average of about 28 days after starting therapy.
I was kind of expected given the monkey data, the monkey data when the infected receive and they are treated right away despite that, and they got suppressed, they stopped therapy, all the monkeys rebound. So
let's look at another strategy to try to limit the size of the latent reservoir, and that's bone marrow transplantation. So this is a group at the Mayo Clinic in Minnesota who did a stem cell transplant in a man with ALL. The donor had CCR5 wild type. It was not a Delta 32 donor. This individual developed graft versus host disease after infection, but I think it was about 6 months into his post-transplant period, all of the cells were basically from the donor. It was nearly 100% chimerism. He stayed on antiretroviral therapy for about 2 years after his transplant, virologic suppression, no HIV detectable in the latent reservoir, stops his antiretroviral therapy, and then 288 days after stopping therapy, has a viral load rebound.
Yeah.
So trying to reproduce the Berlin patient's experience hasn't happened. So I think that these studies show that whatever strategy you're trying to implement to limit the size of the latent reservoir, it's going to be very difficult to know that you've been successful. And the only way to know is by stopping antiretroviral therapy and wait. And you're going to need to wait a long time potentially before you can claim that you've cured another person. So there was an interesting study that was done in Spain, looking at the combination of an HIV vaccine to try to improve the HIV-specific immune response and romidepsin to activate virus from the latent reservoir. And so what they did was they took a cohort that had previously received antiretroviral therapy within 6 months of acquiring HIV and who had gotten a therapeutic vaccine. These individuals didn't interrupt their antiretroviral therapy. Some of them ultimately enrolled in this trial where they got another vaccine, then got 3 injections of romidepsin, then got a boost, continued on their antiretroviral therapy, ultimately stopped their antiretroviral therapy. And in 5 of the 13 individuals who stopped their therapy, there was pretty effective control of virus replication. This is not, these people aren't cured, no. But I think what this demonstrates is that you may be able to modify the HIV-specific immune response in a way that leads to more effective cure.
The pattern of rebound is interesting because it seems like there is some immunity they're trying to work. It's the viral load goes up, goes down. You know, this is,
yes,
it seems that the immune system is fighting.
Yeah. They demonstrated that they really were able to shift the HIV-specific immune response in the direction of the vaccine. And this is a little bit different from a similar study that was presented from Norway a year ago, looking at romidepsin and a different vaccine strategy that did not work as effectively. So more work on therapeutic vaccines, I think, to come. And then lastly, I want to mention this toll-like receptor agonist that we heard about initially last year at this time, 9620. And there was data from a non-human primate model where animals either got a control injection, this particular TLR7 agonist, or an earlier version of this compound. And in 2 of the animals, there was no virus replication after the antiretroviral was stopped. And what we saw at this meeting was a clearer demonstration that these animals have been actually cured of the infection. So maintenance of virologic suppression for longer periods of time off antiretroviral therapy. These animals were also depleted of their CD8 killer cells, which has led to rebound in virus replication in elite control or SIV model systems. And then they took cells from these animals, tried to infect other SIV uninfected animals with the cells, and were unable to do that. So I think this is a pretty clear demonstration that these 2 animals are cured of their SIV infection. So that's pretty interesting data. And then a little bit more data looking at this compound and the immunologic effects that result from it in humans. And they were able to demonstrate that there's probably some effect of the compound on dendritic cells that ultimately mediate polyfunctionality in CD8 T cells, increased killing of killer cells, and better antibody-mediated clearance of HIV-infected targets. So this is, I think, one of the more interesting compounds among the classes of latency reversing agents.
And there are trials already in humans, right?
Yes, phase 1 trials underway right now. Okay. So then, just to summarize this area, we can't limit the size of the latent reservoir through early treatment or through transplantation strategies effectively enough to cure people. I think that's clear. We're going to need some other kind of intervention. Another bone marrow transplant didn't work. We've seen data that has shown that a lot of people die after bone marrow transplants. That's not going to be a strategy to cure people of their HIV that's going to be viable. We're going to need probably a combination of latency reversing agents, modification of the HIV-specific immune response, gene therapy strategies. There was nothing new on gene therapy at the meeting, but we're going to need probably a combination approach in order to cure people of their HIV. So I'm going to stop there.
Great.
And Jose, I'm going to turn it over to you.
Yes, so I'm going to review with you the studies in treatment-naive patients. So there are still, as I think is important, is still development in antiretrovirals, and it's not as big as it used to be, but there is still a pipeline. So here was presented the first phase 3 data of doravirine, that is a non-nucleoside reverse transcriptase inhibitor that is labeled as a 2nd generation because it's active against mutations that commonly selected by nevirapine and efavirenz, and in phase 2 has a nice safety profile. So the goal of this new NNRTI is to try to cover the 2 limitations that we have with NNRTIs is the CNS adverse events of efavirenz and also the weakness of rilpivirine in patients with high viral load. So this doravirine Its goal is to compensate those two weaknesses, is being active in high viral loads and also have a good safety profile.
And it's you're not required to take it with food.
Right.
And you can take it with the PPI. So I think it does add actually
that's
something
that's
on top,
well.
yeah.
So, and then this is the first phase 3 trial is a double-blind, double-dummy study comparing doravirine with darunavir, ritonavir, with two nucleosides. It was up to the investigator to select either TDF, FTC, or abacavir 3TC. And we've seen here the 40-week data, and this is a non-inferiority study with a classical less than 12% margin of non-inferiority. So the baseline characteristics is like we see in most of these trials is patients that are relatively healthy with high CD4s, and I think a quarter of the patients have viral loads above 100,000 copies per ml. So at 40, so this was a kind of a complicated trial because they have to blind darunavir. So patients have to take a high number of pills, and probably that was the reason there was a high number of discontinuations. About 15% of the patients discontinued in each arm for reasons not related to virologic failure. So the bottom line is after 1 year, 84% of the patients randomized to doravirine are below 50 by a snapshot versus 80% with darunavir, ritonavir. It meets the non-inferiority for the primary endpoint. So the question if this is affected by high viral loads, well, the results of the trial are not. Here you can see the results by high viral loads or low viral loads, and the difference with darunavir stays the same. Always true, there is a drop in efficacy, is around 9% drop in efficacy of doravirine. But as I said, the results, the comparison with darunavir is the same. There is also no different the results by the nucleosides that were used or by the baseline CD4 cell count.
And of course the pattern with darunavir is very similar to what was seen in the Flamingo study, where darunavir didn't work so well at high viral load.
Right, right. And the other interesting, I think, which is a very interesting aspect, is one of the first trials using an NNRTI in which no patients with protocol-defined virologic failure developed resistance. There was just not a single case of resistance to the doravirine, suggesting that might have a higher genetic barrier. There was one patient, because they genotype everybody that discontinued therapy. And there was a patient with very bad adherence that discontinued therapy, and they tested the sample after discontinuation, and this patient did have resistance, has two non-nucleoside resistant mutation, and also have 184B. And there was another patient that discontinued due to a rash and had a small change in the phenotypic susceptibility that is questionable. The impact went from 2.2 to 2.5. So, but I think this is interesting data. We have a non-nucleoside that it seems to have a higher risk.
Yeah, well, but I think it's very difficult to say from a phase 2 limited number study, because in the end, the one patient, although maybe it's not protocol-defined virological failure, but he did have resistance in the setting of non-adherence. So if you have a larger trial, and people are not adherent, then
Jürgen, this is large. This is phase 3. This is almost 700 patients.
Yes. Yes, so I think we have to be cautious. I don't think that we can.
No. But
later in the year, we'll see a second trial against
efavirenz,
efavirenz, so we'll see if they can do the same trick again.
Yeah, the same trick. So we'll say, well, it's fair to say it's among almost 400 patients exposed to doravirine. There was just one patient who stopped and had resistance. But we will have to see. And in terms of toxicity, there was no signature toxicity for doravirine. There is no CNS adverse events. As expected, there was less GI adverse events with doravirine than with darunavir, ritonavir. Discontinuation rates for adverse events was very low, 2% and 3%. And when looking at lipids, there was an advantage in fasting total cholesterol and LDL and HDL cholesterol. This was very minimal impact of the doravirine, while as expected, darunavir had a higher impact in lipids.
Actually, just one other comment about doravirine. One of the interesting things is it's going to be co-formulated in a single pill with generic TDF and lamivudine. So I think it'll be interesting to see how it performs in that context not with the nukes that we're currently using.
There is a switch trial exploring that combination of basically from boosted PIs.
But I think that working in the above 100,000 copies, I think is a good signal, because that's something we have been looking for in the NNRTI.
Yeah.
Okay, we saw also a phase 2 trial looking at a new integrase inhibitor called bictegravir. That is a non-boosted integrase inhibitor. It's a second generation integrase inhibitor. It's very similar in many aspects to dolutegravir. If you look at the resistance profile, at least in vitro, it's active against the most common mutation selected by first generation integrase transfer inhibitors such as raltegravir or elvitegravir. So it's kind of a new type of dolutegravir type of drug, and we've seen the results of phase 2 comparing bictegravir with FTC-TAF versus dolutegravir FTC-TAF. It's a small trial. It's close to 100 patients, and it's a double-blind, double-dummy trial. The results here...
I think it's important to note that it's 2-to-1 randomized, because it results in the dolutegravir group being quite small, because often it's just one person either way that influences those numbers.
Yeah, thank you for saying that. Here it's also important to stress that here bictegravir was taken as a single drug combined with FTC-TAF, but the development is going to be in a fixed dose co-formulation of bictegravir FTC-TAF, and the dose actually is going to be slightly lower in the fixed dose formulation because the bioavailability is improved with the fixed dose formulation. So, and true, this is phase 2, so I wouldn't make any claim about the comparison because, as Graham said, it's also 2-to-1, but the efficacy rate was quite high. At week 24 was the primary endpoint, is 97% undetectable versus 94, and at week 48 is 97 versus 91. There was not a single case of virologic failure with development of resistance in any of the two groups, and in terms of toxicity, both were well tolerated. There was very little differences in adverse events between bictegravir and dolutegravir, and also the most common laboratory abnormality was high CKs that we tend to see in most of these trials. So this is a full phase 3 is ongoing, and there is going to be comparisons versus dolutegravir. There's going to be also switch data. So it's important this fixed dose combination can be given without regard to food. So has the same interactions with also with cations that other integrase inhibitors. But we're going to see it's interesting compound, and we're going to see a full phase 3.
And also has some interaction with renal transporters, and there's also an increase in creatinine.
Right. It has also interferes with the OCT.
It's less than with dolutegravir.
It's less than with dolutegravir. Interaction with metformin is less also.
It's less, so
it's a
little bit different.
It's a little bit different. So, and a big theme in this conference has been also the use of reduced drug regimens to treat HIV or to maintain suppression. We've seen an update of the LATE study that combined cabotegravir and rilpivirine orally for maintenance of virologic suppression. And I think it's important for these strategies to have long-term data. This is the 144 update of 3 years of the trial. In total, it's 181 patients that received different doses of cabotegravir. The overall suppression rate after 3 years is 67%, as I said, with dual therapy with cabotegravir and rilpivirine. I think in total there were 9 virologic failures in total. Of those 9 virologic failures, 5 developed treatment-emergent resistance. So this was the study that paved the way for the long-acting formulations of both drugs, and so this combination is not something that we are going to use in general, only in the induction phase for the long-acting. And let me remind you that orally cabotegravir is a slightly worse drug than dolutegravir, has a lower genetic barrier.
Very clear. There's a lower genetic barrier. There's been a resistance in a number of cases, as we saw in the macaque study that was presented by him.
Right, but it's interesting that that after 3 years, this dual therapy still produces high levels of suppression. But I think it's the take-home message is we are not going to use this combination a lot because the emphasis is in the long-acting that is ongoing. So, and to me, this in terms of antiretroviral therapy, the biggest news of the conference was the results of the SWORD study that is. Full-powered. Actually, there are 2 trials. This is a pool analysis, but it's a full-powered clinical trial. The goal was to demonstrate if dual therapy with dolutegravir and rilpivirine matches the efficacy of triple antiretroviral therapy for maintenance of virologic suppression. So these were patients. It's a classic switch trial. Patients who are undetectable for at least 1 year. This is slightly different from other trials, taking 2 nucleosides and a third drug, an integrase inhibitor, or a PI or an NRTI, and they have to be on the first or second antiretroviral therapy with no changes due to prior virologic failure. So it's kind of a selected population, quite adherent. They have to be undetectable for 1 year and without any prior virologic failures. They get randomized to receive dolutegravir plus rilpivirine or continuation of the antiretroviral therapy up to week 52. At week 52, everybody will switch. It will be a late switch. Everybody will switch to dolutegravir and rilpivirine, and this is a multi-center, multinational trial. These patients were around 43 years old, and 1/3 were about 50. The CD4 cell count was high. These patients have been suppressed for a prolonged period of time, and almost 70% were about 500 copies per ml. And half of these patients were taking NRTIs, and the other half were taking either PIs or integrase inhibitor, and 2/4 were taking TDF. The duration of antiretroviral therapy months was almost 50 months.
I think the non-nucleoside aspect is very important because they tend to be induction agents, efavirenz or nevirapine, particularly not rilpivirine, which have significant impacts on both dolutegravir and rilpivirine exposure. So it's a pretty critical issue to test in that subgroup.
I think they have, I can't remember, but they have a limit on the patients who were receiving rilpivirine or dolutegravir in the trial. So the most important result was efficacy, and efficacy by a snapshot after 1 year of follow-up. The control arm did very well. 95% of the patients were undetectable after 1 year, so the control arm is a very good match. And dolutegravir rilpivirine really had exactly the same efficacy rate, 95%. So meeting in each individual trial and in the pool analysis met the non-inferiority criteria. The point estimate is minus 0.2. So I think it's for the first time a nucleoside sparing, boosting sparing regimen after 1 year has matched the efficacy of triple therapy. So I think those are big news. Of course, we will have to see long-term data, and we will have to see how these in longer follow-up if these results are maintained. But I think it's as good as a beginning as we could expect. In terms of the snapshot analysis, the only thing that really caught my attention is that there were more discontinuations due to adverse events in the experimental arm with dolutegravir 3TC. 17 patients discontinued. And these were canceled out by discontinuation for other reasons in the continuation arm. Patients switched completely, many of them switched completely the regimen for 2 new drugs. And it's true that that increases the risk of having some adverse events. As I said, it's 3% of the patients. It's true that there are more adverse events, but the overall efficacy rate is very high.
Yeah, but it's 2 new drugs. The other ones are staying what they already have been taken on average for 50 months. So anyone who had problems before is sort of filtered out.
Yeah, I think we've been switching people now for a long time off regimens if there's any evidence of intolerance. So I think people
that's also the problem in a randomized study. if people say they want to go in because they want to get the new treatment and they don't get it, they tend to drop out of the study, whereas in practice, that tends not to happen.
And that may be true too.
The other advantage is this is really very small pills that you have to take. Dolutegravir and rilpivirine. It will be 75
single tablet regimen.
It will be 75
milligrams.
Right, it's going to be. And also, when we are playing with the number of drugs, there is always the worry about resistance development. And really, here there was just one patient that meet virological withdrawal criteria that had a single NRTI associated mutation, K101K. Actually, this patient didn't have integrase resistance and resuppressed in the same regimen. So it doesn't seem also that there is an increased risk of resistance when we are giving dolutegravir along with rilpivirine. In terms of adverse events, well, there was 21, and it was a mixture, but it's true there was few patients who have CNS adverse events that have either insomnia, depression, or some anxiety. That was the only thing. Well, I think this is, as I said, short. I think we will.
There is a fixed dose formulation being developed, so that's an important thing to
Yes, it's
to
going to be
remind
very
folks.
simple regimen. It's not going. It doesn't have a booster in it and no nuke. And I think when you think of some of your patients with nuke toxicities or resistance in the nuke class, that is an interesting option, I think.
I think is going to be the debate that we're going to see. Like we're going to have, for example, bictegravir if its results are good in phase 3, but will be bictegravir with TAF FTC, triple regimen with safe drugs versus also double regimen with very safe drugs too. So
this will have the food requirement that rilpivirine has with it, of course.
Yeah. So and we saw an update also of TAF versus TDF in the 104-111 trials, along with FTC and elvitegravir covistat. And so is this still after 3 years? The trial is double-blind, double-dummy, and for the first time here, TAF outperformed TDF. There was by a snapshot a 4% difference, but since this is a huge sample size, this difference is statistically significant. And the driver of the results were the discontinuations in the TDF arm. There was in total 6 patients that discontinued due to their clinicians were worried about the decrease in bone mineral density, about 5%, and there were 8 patients that discontinued also due to renal adverse events. So while there was not a single case of discontinuation due to renal adverse events in TAF, nor not a single case of discontinuation due to a decrease in bone mineral density in the TAF arm, suggesting, that this is the context of a double-blind clinical trial. So it's suggesting, and also it's important that the discontinuations with TDF occurred throughout the trial. There were discontinuations between week 96 and week 144, while the TAF discontinuations occur mostly at the beginning.
The difficulty is that we don't DEXA scan people for their bone mineral density, at least under the age of 50 routinely. And does that mean we're missing something?
Yeah, we might, because these were hard endpoints. I would say it's more than 5% decreased gram is worrisome. So I think those.
I think it strengthens also the renal safety profile of TAF, because you then really see that even over 3 years, it's not one signal at all, whereas there are continuous signals in the different in the other preparations. So I think it's an important result.
Yeah.
As we're monitoring people less frequently, having a drug that is a little bit safer from a renal perspective, I think, gives you a little bit more confidence that you can wait for a 6-month period of time before measuring a creatinine and knowing that you're not putting someone at risk.
Yeah, is the decrease in bone mineral density with TAF was minus 1.3% at the beginning and really plateaus after that, and with TDF is 3%. That's the number that we always mention. As I said, there is not still in the development of TAF a single case of discontinuation due to renal adverse events. So, and there were a couple of other interesting observations. There was a presentation from 3 different cohorts, one included from Barcelona, another from Canada, and another from Germany, that put together all their patients receiving dolutegravir monotherapy for maintenance of suppression, and there was a high risk of failure, almost 10%, and 99 patients developed integrase resistance, including patients who have never been treated with an integrase inhibitor. And as we will see later on, I think this is one of the studies that really has closed this road. I think dolutegravir monotherapy is clear that it has a higher risk of virologic failure and development of resistance.
Yeah, I mean, the message I think is very clear. There should be no monotherapy with dolutegravir.
This is really in a very striking contrast with triple therapy with dolutegravir, or even what we've seen with dual therapy with dolutegravir. And there was also an interesting study of using ibalizumab. Ibalizumab is a monoclonal antibody against the second domain of CD4. So that is important because it doesn't interfere with the physiologic activity of the receptor. And this is given weekly IV, and we saw the results of salvage therapy in a small trial, but it's anything is important because we still have patients that really need rescue therapy. It was 40 patients, 53, half of them have exhausted at least 3 classes of antiretroviral drug. Many of them, if I remember okay, half of them take it also with fostemsavir. There is an attachment inhibitor. Actually, we don't have those many patients, but actually we have an armamentarium now to treat them.
There was also Pro-140 reported here, but you have to be CCR5.
CCR5, that's another very interesting compound. I think we are seeing an explosion in monoclonal antibodies, and as Graham mentioned, we have Pro-140 that is an anti-R5 receptor. You have to be, but it's also, and there is also a new fusion inhibitor. Right.
Yeah, it's a long-acting version of it.
Long-acting, it's albutertide. So we really have, weapons.
Yeah, the capsid inhibitor.
Right. So there was almost 50% of the patients have a 2-log decrease, and 43% of them were undetectable after 1 year of follow-up. This with ibalizumab. So take-home messages is doravirine is non-inferior to darunavir/ritonavir. There is good tolerance. Results of the trial were not affected by baseline viral load, by CD4, or the nucleoside combination. And remember that we have a new integrase inhibitor, bictegravir, non-boosted, once daily. Phase 2 study has so high efficacy with limited number of patients with no resistant development. Dolutegravir rilpivirine dual therapy, non-inferior to triple therapy for maintenance of viral suppression, with apparently not an increased risk of resistance, and TAF superior to TDF after 3 years, mainly due to more discontinuations due to renal and bone adverse events with TDF.
Okay, so excuse my croaky voice. This is the best voice I've had this week. So I'm going to talk about some aspects of adverse events, and starting off with some data from the NA Accord. It really has a rather simple message around it. They took a very large number of individuals within the NA Accord and looked at what are the relative contributions of traditional and HIV-related factors to developing a myocardial infarction in NA Accord. And surprise, surprise, smoking, hypertension, hypercholesterolemia are the big players in cardiovascular risk, our traditional modifiable risk factors. And there was quite a lot in the conference, as I'll go on to show in a moment, about getting your patients to stop smoking and how we need to be much more aggressive about that. When we look at the contribution of aspects of HIV therapy, there are a couple of things that play a role: having a detectable viral load, having a low current CD4 count, so late diagnosis is critical to the risk of cardiovascular disease, and then there may be small contributions from medication. And of course, HCV playing a role, the mechanisms which are unclear, whether it's inflammatory or whether it's because of insulin resistance as potential mechanisms. So simple message. Now, of the drugs that have been looked at in the DAD study so far for risk of myocardial or broader cardiovascular events, it always has a lag time because people have got to be exposed to our new drugs and then to have a sufficient number of events to be able to statistically assess them.
Yeah, but I think that's a great thing about DD. They defined that they're only going to make a judgment on a drug if they have, I think, like 20,000 person use or something like that.
That's right. So it's never going to be a speculative outcome. It's going to be, we're pretty clear that this is something that's happening. So they previously reported a couple of years of follow-up with atazanavir that didn't suggest there was a signal with atazanavir around myocardial infarction risk. Longer-term follow-up has supported that original assertion that there doesn't appear to be an association between atazanavir use and myocardial infarction risk. But rather like they'd described with Kaletra and indinavir in the past, there was a cumulative exposure of risk of myocardial infarction with darunavir, ritonavir. Now, they weren't able to tease apart whether this was 600, 100 BD or 800, 100 BD once daily, although we know that most of the use is once daily.
And they have this proxy of using it as a first PI or second PI.
Yes.
Probably means that as a first PI will be QD, right?
Correct.
Okay.
And they were able to adjust for a lot of things. And notably, just adjusting for lipids doesn't take away the risk from the product. So it becomes quite similar to what we see with lopinavir, or perhaps a slightly higher number, which is that adjusted 5-year risk of exposure, you're increasing myocardial infarction risk by 1.59%. This is not an abacavir-like story, where abacavir is an on and off risk for myocardial infarction. This is a cumulative exposure risk.
It's not increasing it by 1.59%. It's a
Fold.
It's a fold change. So
Yeah.
Fold change. Yeah. And compared to abacavir, abacavir was 3 times, right?
Abacavir was around closer to twice, but it wasn't a cumulative event. It was a short-term effect of if you're on the drug or not on the drug, or you've been on the drug within the last 6 months. So abacavir doesn't have much of a cumulative impact. The protease inhibitors do appear to have a cumulative impact, except for atazanavir.
So you think this is a class effect that the atazanavir doesn't happen because of the bilirubin?
That's a possible answer.
But I just want to say, though, that when you think of it, lopinavir was associated and indinavir both were associated with an increased risk for insulin resistance. They had different lipid impact than darunavir. So it's a little surprising, I would say, because from the metabolic profile and all the the insulin testing and all that never had a signal of that sort. So how do you explain?
So we'll talk about that in terms of what Jose just said, because this is actually concordant with what was seen when atazanavir and darunavir were compared for the effect on carotid intimal thickening in 5257, and darunavir progressed more rapidly than the atazanavir group, and raltegravir, which is incredibly lipid and metabolically benign, was actually intermediate to the two for that effect. So one hypothesis is that all of the protease inhibitors do something. It's not just about lipids and insulin resistance, but atazanavir is saved by its impact on bilirubin. And there's been a few studies before that have teased at this. There was these data from the VA cohort, which I think more effectively nails the story. There are multiple cohorts in the general population that suggest bilirubin may be associated with a reduced risk of myocardial infarction and or other cardiac events, including heart failure. This was looking at people essentially with normal range bilirubins, but looking across the range from the low end of the normal range to the upper end of the normal range. So it's not necessarily just people with Gilbert syndrome, and it certainly wasn't necessarily people on atazanavir. But the higher your bilirubin, the less likely you were to have heart failure or a myocardial infarction. And when they looked at the over 30,000 people who were HIV positive in this, the bilirubin effect remained statistically significant in that smaller group for heart failure, and the trend for myocardial infarction remained the same. So a little bit more bilirubin is not necessarily a bad thing, and there's a little bit in the cardiac literature that says it'd be nice to have agents that raised bilirubin at least a little bit because of this effect. They have not nailed that atazanavir raising bilirubin results in this benefit, separate from an independent effect on bilirubin, such as variation in UGT1A1. So I mentioned smoking earlier as the key modifiable cardiac risk factor. This was data from DAD where they were looking at what happens if you stop smoking during the course of DAD. What happens to your risk of developing any malignancy, smoking-related malignancies, or specifically lung cancer. So the good news first was that individuals who were an ex-smoker already at entry into DAD or had stopped smoking for 3 or more years started to see all-cause cancer becoming a background rate similar to people who had never smoked. And that was also true for smoking-related cancers, except for lung cancer. And with lung cancer, even if you'd stopped smoking for 5 years or more, the risk remained similar to people who were current smokers. So
we know that from HIV uninfected populations.
Yeah, and the suggestion from the uninfected population is you start to see a benefit of stopping smoking 15 years or thereabouts beyond. So DAD is recapitulating that in people with HIV, stopping smoking is beneficial. It's a key risk factor for cardiovascular disease. It's a key risk factor for all cancers and specifically smoking-related cancers. But for people who have smoked, surveillance for lung cancer remains critical and needs to be long-term as part of people's management. So, Jose has already made some comment about dolutegravir monotherapy. Again, it's a simple story here. Don't do it. At 24 weeks of this study that we saw at Glasgow, you might remember that the dolutegravir group had performed quite well. My scale here is not the most beautiful on the slide, but there was only one additional failure, an individual who discontinued because of insomnia in the dolutegravir arm. They had discontinued the control arm of the study after that time point, but continued to follow individuals, and they saw additional people with virological failure, so that out at 48 weeks, 77 people who'd originally been randomized in the study onto dolutegravir monotherapy had failed, 8 out of 77. 6 of them had amplifiable genotypes, of which 3 of those 6 showed integrase resistance. And those integrase resistance mutations that were emergent included familiar and unfamiliar patterns. And critically, they included people who failed with a single mutation, suggesting the genetic barrier may be one mutation, but it may be just one difficult to emerge mutation. And the study was then stopped by the DSMB, and the authors recommended against that. And I believe there's been at least one other dolutegravir monotherapy randomized study that's also been stopped. And then, as Jose mentioned, there was a combined analysis of several cohorts, which also found multiple pathways to resistance in individuals failing on dolutegravir monotherapy. So this is a simple learning point. We're not going to do that. So Jose's already mentioned the idea of reduction therapy, and this is another approach with dolutegravir. We've heard about using it with rilpivirine in a fully powered phase 3 study. This is the idea of, can we use 3TC with dolutegravir to create a complete regimen for maintenance. And so this study, Lamidol, conducted in France, it's a cohort study. People were required not to have failed on previous treatment, and that they were all rolled over, 110 of them, to take dolutegravir 3TC. So there was no randomization, no control here, but the key issue was that there were very few adverse events, and that there was only one individual who experienced virological failure, and I believe that person resuppressed on continued treatment.
Yeah, very low level.
Anyway, the adverse events reported, there was a suicidal ideation in the 8-week period where people switched from their original therapy to 2 nukes plus dolutegravir, and then the other events occurred after they dropped the second nuke from their regimen, which were 2 of them were certainly unrelated to the treatment regimen.
This could be a very attractive combination for many reasons. You know, 3TC is going to be generic.
Yeah, and so this to a certain extent follows on from PADL, and there are now large-scale studies called the Gemini program that are looking at this combination in initial therapy, as well as a potential for a maintenance therapy that again will be a chimera, as it were, between a generic agent and an on-patent agent that provides a good value proposition. So just looking at discontinuations to dolutegravir, there's been quite a few cohorts in recent times that have tried to address this issue. This is looking at different combinations of drugs of dolutegravir, raltegravir, or elvitegravir. Of course, elvitegravir is fixed with its backbones. The other ones can have a choice of nucleoside backbone. In terms of the rates of discontinuation, overall they were quite similar between the different integrase inhibitor products. Curiously, in this study, it was slightly higher in raltegravir, whereas generally with studies with raltegravir, we've seen that it's a lower rate. When they then looked at specifically neuropsychiatric toxicities, which they included anxiety, depression, dizziness, insomnia, nightmares,
Headache.
paresthesia, which I'm not sure is a central nervous system effect, somnolence, tremor, and vertigo, not headache on the list.
Not headache in this study.
They found that there was an excess in the dolutegravir group. It was a small excess compared with what has been described in other studies, such as the Hamburg study that we saw at Glasgow. And in this case, it wasn't a whole lot different whether it was tenofovir FTC or abacavir 3TC as the backbone, whereas the Hamburg cohort had suggested abacavir co-administration might be a risk factor. So we're seeing the syndrome. These perhaps to me look more like realistic figures to what I've observed in clinical practice.
Yeah, so I mean, if you think of the initial report, which was from the Dutch, it was like a two-digit percentage, right?
So 17%,
yeah. So this is really very different, and I think does raise some questions when a drug enters a court completely new, and there may be a different story of feeling comfortable with certain side effects or giving it a chance to manage it, rather than switching right away. So because it's really quite, I mean, it's a much larger number of patients than the Dutch court, and the numbers are, I mean, extremely different, right? So I think that does flag some questions.
And I think here the discontinuations of dolutegravir due to neuropsychiatric toxicity were clearly higher with abacavir 3TC than with TDF-FTC.
Yeah.
It's 2.1% versus 3%. But I think I agree that this syndrome exists, but I think the numbers is critical. It's not really the 16% that we saw.
It's not really the 16%. No. I think it's actually because the Spanish are relaxed and happy people, so the anxiety and depression is less likely, and they sleep at funny times of the day, so there's no insomnia.
You're going to say with Spanish red wine, depression goes away.
Couldn't agree more. Couldn't agree more.
So an interesting report that was expounded from something that we saw at Glasgow from Japan, looking at people who experienced a CNS effect on dolutegravir. Now, they didn't report the grading of these effects, so we don't know whether these were simply people saying, I haven't slept so well, or saying, I'm tortured by insomnia at the moment. So we don't know what the limit of the effect is. But what they noted is that as you go up the exposure quartiles of dolutegravir and get higher and higher levels of dolutegravir, these effects seem to be reported more commonly. I think the implication is that it's a dose-dependent effect, and therefore it's a real effect of dolutegravir. The curiousness about difference between tenofovir and abacavir is that we don't think there's a drug interaction between them that influences that. But it does underline that if there are drug interactions with dolutegravir, potentially that means that there's going to be more adverse effects to watch out for if dolutegravir levels are increased. So the key points from the first section: traditional modifiable risk factors for myocardial infarction are critical to managing cardiovascular risk. Amongst the protease inhibitors, atazanavir appears to be the one that hasn't been associated with risk. This is the first report of darunavir having been associated with a cumulative exposure increasing risk. Getting our patients to stop smoking is critical for cardiovascular risk, critical for malignancy risk, but lung cancer surveillance needs to persist in the long term. And then we've got some novel regimens coming along. Dolutegravir monotherapy is not one of them. Dolutegravir plus rilpivirine or 3TC are potentially one of those. And dolutegravir is a very well tolerated drug with a very favourable drug interaction profile, but some people do get bothered by central nervous system side effects and therefore may lead to discontinuation in some individuals. Now, following on from what Jose presented, this is the follow-on from the WAVE study that was a randomized study that looked at tenofovir DF, FTC, atazanavir, ritonavir versus tenofovir DF as part of STRI-BUILD. And at the end of the study, they rolled people over to then take the Genvoya formulation of TAF, FTC, FTC, elvitegravir, cobicistat. And again, for people who switched off the atazanavir or off STRI-BUILD over onto Genvoya, they had some people who continued on atazanavir. There was an improvement in tubular protein loss, there was an improvement in bone mineral density, and there was some improvement, some alteration in lipid profile. The tenofovir DF is a lipid-lowering drug. You reduce the plasma exposure of tenofovir. TAF doesn't have quite the same effect, but the changes in lipids are pretty modest with that regard. So more supportive data with that switch, particularly around the areas of renal and bone. So a few words about drug-drug interactions. So there was a separate presentation about bictegravir and some drug-drug interactions. And there are 3 potential points where drug interactions may occur beyond the OCT1 interaction that has already been mentioned. Those are cytochrome P453A, the non-cytosolic enzyme UGT1A1, and the transporter PGP. So bictegravir appears to potentially be a victim of interactions at all of those sites, sometimes leading to increased exposure of bictegravir, sometimes leading to lower exposures of bictegravir. So that they saw effects with atazanavir, and then those effects were slightly exaggerated by cobicistat, atazanavir being more of a probe for UGT1A1 inhibition, the cobicistat adding in a whole lot of CYP3A inhibition. Drugs that induce the PGP and the P450 system, such as rifampin, will lead to quite marked reductions in exposure of bictegravir, whereas probably with rifabutin, the interaction's not going to be quite so important. So there'll be quite a few interactions to solve with bictegravir, and it suggests that it might be more prone to being influenced by drug-drug interactions than what we've seen so far with dolutegravir. So often when we think about cobicistat, the advice is cobicistat and ritonavir are similar to each other. But of course, cobicistat is a bit more of a pure CYP3A inhibitor, not completely pure, has some off-target activity, but ritonavir is very impure and has a lot of off-target activity in terms of enzyme induction within other P450 enzymes. So when we're looking at anticoagulation therapy, dabigatran is a popular option that we have there. This was a drug interaction that looked at the influence of ritonavir versus cobicistat on dabigatran and showed opposite effects. Ritonavir was associated with slightly lower levels, although probably not enough to lose the therapeutic effect from dabigatran, whereas with cobicistat, the dabigatran levels were doubled. So an important practice point that if you're considering changing somebody who's on a dabigatran to one of the newer formulations, such as Risolster or Evotaz or Prescobix, as it's called in the United States, then you may need to adjust for some of your background treatments, of which dabigatran is now on that list. Second drug where an interaction may be relevant was looking at people who were taking dolutegravir with darunavir, ritonavir, and changed over to darunavir and cobicistat. That change from ritonavir to cobicistat didn't meaningfully affect the darunavir levels, although we have published data to say that the darunavir tail is slightly different out beyond the 24-hour time point. But what was noticed was that there was a marked increase in exposure of dolutegravir when cobicistat was used relative to ritonavir. So again, if you're constructing a simplified salvage regimen, as it were, where you're going to be using an integrase and a boosted PI, consideration needs to be made for the differences in interactions that may occur, particularly as we see that higher levels of dolutegravir may be associated with a higher risk of CNS effects.
And that's not a combination that I've used a lot, dolutegravir and cobicistat, because both of the drugs can have an impact on distal renal tubular secretion of creatinine, and you can see, even more of a change.
There was a paper presented at Glasgow looking at darunavir with a fixed dose Stribild or Genvoya tablet as a partner, where the cobicistat was boosting the elvitegravir and the darunavir as part of I think it's a simplified salvage regimen, I'd call it. Yeah. So it's a possible regimen, and it's a possible regimen that we might look at in terms of therapy simplification. The last thing I was just going to cover, we know that we need to be surveillant about cervical cancer in women with HIV and make sure that they're smeared or colposcopied on a regular basis. This was a randomized study looking at individuals with CIN, most predominantly CIN2, who were randomized to have that treated with cryotherapy or with loop electrocautery, and looked at the time to recurrence of CIN after that treatment. And there was a significant advantage to using the electrocautery. So if you're in a center where electrocautery is not available, which might be a resource-limited setting or an outpatient service not linked with the main hospital, then you better try to refer that on to somebody where the loop cautery can occur. So, thank you very much.
Hey, just one thing before we go on. There's a lot of data on obesity at this meeting, particularly after initiating antiretroviral therapy. I thought it was interesting that they showed some of the correlations between weight gain after initiation of antiretroviral therapy and women and individuals who start therapy with lower CD4 counts are at increased risk of having significant weight gain and moving in from a normal category into an overweight or obese category.
All the DAD data suggested that didn't result in them having worse outcomes from, for example, a myocardial infarction standpoint.
I think BMI is going to play a bigger role also in the context of fatty liver disease. So why not, let's talk a little bit about liver disease and liver-related complications. So if you have followed this program over the last years, you're coming to the end.
You have full 15 minutes.
All right, so let's see what was new about hepatitis altogether. And I think the first study I want to talk about is the Swiss cohort, where they looked at routine PCR-based hepatitis C screening. So they looked at all their MSM in the Swiss cohort and identified 178 who had hepatitis C in the MSM population, so 4.8%. I think it tells us pretty much in all the MSM cohorts that the amount of patients with hepatitis C is actually increasing. You see the genotype distribution there. So in Europe, it's really a dominant genotype 1-4 infection, MSM, and very little 2 and 3, whereas in some of the other outbreaks in the world, particularly in Asia, you actually do see some genotype 2 and 3 infections. So really telling that it's happening at different places with different genotypes. And the interesting thing was that they did identify 31 patients with acute hepatitis C, of whom 21% were antibody negative, and two showed normal liver enzymes. So it really tells you that if you have the suspicion of acute hepatitis C, you'll have to do the PCR as well, because you may fall into that window where no antibodies have been produced yet. Remember that that is linked also to immunodeficiency, so if you have a very low CD4 count, it can actually take up to a year to develop antibodies.
And of course, people who've been treated previously need to be screened in that way and followed up for reinfection risk as well.
Great point. So obviously, if once you're positive antibody-wise, you're going to stay lifelong positive in most cases, and then if you have suspicion of a reinfection, you really have to do the PCR to confirm that. Now, I think one of the highlights of the oral hepatitis session was really around the idea of, so what if we increase uptake of therapy and take into account that this outbreak of acute hepatitis C and MSM is occurring, can we eliminate hepatitis C in that group if we would treat everyone? And the group from the Netherlands, which have a sizable group of patients to treat, which obviously cost-wise also makes it sort of attractive to think about that, presented first their data of uptake of DAs. And the interesting thing here is that whereas they initially started off with a very typical only patients with F3, F4 have access to DAA-based therapy, since November 2015, they now have unrestricted access to DAA, really allowing to treat everyone with chronic hepatitis C. So in their cohort, the Athena cohort, and I think the great thing about the Athena cohort is captures 95% of the Dutch patients, so it's very representative. They identified 1,420 patients with hepatitis C or retained in care, and you can see how the patients then break up between ever treated and in green is the treatment with DAA, and in red is the ones with DAA-based but still containing interferon. And you can see so that the majority of patients then obviously have been treated. So in January 2017, 70% of the entire population are cured. So there are only 30% left. So, and remember some of the other cascade of care presentations at the conference, that is really a huge success. Only 300 patients remain which have never been treated. Some are currently untreated, and then there's some patients who sort of failed that first DAA interferon-based therapy and are now waiting for retreatment. But really telling you that they have a high uptake. And then they also presented data, if they specifically look at the MSM population, which were more likely to be treated because there's a higher urgency and the risk of transmitting it to somebody else, 76% were cured. So really reaching 3/4 of their MSM patient population. Now, in the Netherlands, they had a very early acute hepatitis C study, which looked at boceprevir, PEG, and RIBA in 2014. And then in 2016, they started a new trial with grazeprevir and elbasvir, so an all-oral interferon-free regimen. And this included quite a number of centers and accounts for over 50% of all the acute hepatitis C cases seen in the Netherlands. And they observed a decrease in the overall incidence of new acute hepatitis C cases from 1.1% per year in 2014 to 0.55% per year in 2016. And you see the breakdown of the risk ratios, incidence risk ratios, also for the first months, January to June, so that first half year of 2016, where it was 6.9 per thousand, and then went down to 4.0 per thousand. So there's really strong suggestion that that high exposure of DA in that cohort, 76% of MSM successfully treated, and having the two huge treatment protocols really has had an impact on the overall occurrence of acute hepatitis C, suggesting that that is a good way of eliminating this epidemic in this cohort. And so I think that is sort of the first cohort which shows that. There are other cohorts in place in Switzerland are trying the same approach, and I'm sure we're going to see more data around that. In parallel, though, that's also sort of was used as an argument that this is really related to the DA uptake increase. They do see an increase in other sexually transmitted diseases. So the only thing which is going down is really acute hepatitis C. Then there's still some discussion, there is still a difference between HIV, HCV co-infected and mono-infected patients, and this is data from a larger German collaboration, which includes over 1,000 mono-infected patients, 349 co-infected patients, significant amount of cirrhosis in there. And I think the good news, as in any cohort of this world, if you use DA-based therapy, you have high success rates of 95%. And you see that really the overall response rates does not differ at all, 95 versus 94. But if you go into the HIV patients more specifically, you will see that if you have a low CD4 count below 350 and cirrhosis, you're less likely to achieve a cure. And I think that's one of the things which remind us that if you wait till patients they're cirrhotic, that's going to have an impact on your response. And also a lower CD4 count here seems to play a role, although I would argue that if you have a lower CD4 count, that is when you have faster fibrosis progression, so your probability of having cirrhosis is also higher, so that sort of overlaps.
And they had lower CD4 counts because they were later presenters and have only recently been treated.
Exactly. So
it looks like the SVR rate isn't so good, but these data also include people who are on ribavirin-inclusive regimens or Sim-Soft combos that we're less likely to use these days.
Yeah, exactly. So I think that's also one of the issues when you look at the overall, distribution of different regimens. We started off with Sim-Soft. Remember that there was not a recommendation to do resistance testing prior to Sim-Soft. It was in the context of Sim, PEG, and RIBA, because we knew that the Q80K had an impact, but we also know that cirrhotic patients, when they get Sim-Soft, actually do respond less favorably if they have the Q80K mutation, and that was not controlled for. So I think you're right that the regimens have improved since the first oral DA combinations became available. One of the issues which remains, though, is obviously if you have hepatitis C and you have liver cirrhosis, we all know that you remain at risk for developing hepatocellular carcinoma. That may be decreased, but that's something you still have to check for. Now, there have been some reports which have raised the question whether potentially even the risk of developing HCC after obtaining SVR is increased. And that has been studied in various mono-infected cohorts, and this is, I think, the first larger look at co-infected patients. And so what they did is in Spain and 32 centers, they gathered the data of all patients who developed a hepatocellular carcinoma, and that was then analyzed to different time periods depending on which regimens were available. So it was the non-modified interferon era, the pegylated interferon ribavirin era, the DAA plus interferon era, and then the all-oral era. And what you see is that numerically, there was an increase in the numbers of patients who had HCC in the DA era, which I think is a mere reflection that more patients suddenly can be treated with advanced disease. And it's obviously easier to treat if you don't have to use interferon in that mix. However, if you look at the frequency of the cancer diagnosis after SVR in a cohort of patients who have liver cirrhosis, so here they had data only from 19 centers, who sort of reported all the patients they had with cirrhosis and were treated, then you see that actually the percentage of HCC diagnosis numerically does not increase at all. So at least in this study, there was no signal. And I think it was also interesting because some of the reports have been that in the mono-infected groups, there was then a more aggressive course. So if recurrence of HCC occurred or a new diagnosis was made of HCC, that was usually a very aggressive course, but that was not really confirmed here.
What's the current recommendation for the monitoring of patients after they achieve SVR with regard to HCC?
Yes, so any cirrhotic patient should be monitored every 6 months by ultrasound. There is a discussion around the use of alpha-fetoprotein, which many centers do, but which is not really routinely recommended by the EASL guidelines.
The problem is that alpha-fetoprotein is often raised in cirrhosis anyway, so that it's not
exactly,
a very good marker.
So it's not a very good marker. But
the issue with these data is that they're not time adjusted, are they? So the people who have been treated with interferon regimens have had much longer follow-up to accumulate risk, whereas you've got relatively shorter follow-up in people who have received DAAs.
No, I think it was time adjusted, but the issue here is, you're right, is that the observation period is much smaller, so that is a limitation, and they highlighted that, and that actually the lower or shorter follow-up may explain some of the lower overall rate here, and that may be something to account for. But some of the initial reports were that actually the risk of HCC occurred pretty fast after achieving SVR, right? So at least here it's fair enough to say that in that short observation period thereafter was no signal of a faster rate immediately after obtaining SVR. So I think that is sort of good news, but yes, monitoring of HCC remains an important part, and it's always important because you think, sort of people think like, I'm cured, I don't have to worry about that anymore. No, if you have had cirrhosis, that's something to watch out. And I think also important to highlight that reversion of fibrosis upon fibroscan may not actually reflect what's really happening, and that you really do still remain at risk. Then obviously we're all looking forward to new drugs. Is there anything happening in the hepatitis C treatment era? And this was one of the first conferences where we saw no new phase 3 or any kind of sort of co-infection trial with new drugs, but there was some PK data from a new fixed-dose combination of glargapavir, bemnifosbuvir, so it's a PI with an NS5A inhibitor. It's from AbbVie, and the interesting features of this drug, which probably can be expected to be licensed later this year, is that it's again a pan-genotypic combination which offers high activity for all genotypes. Obviously that's something we only have some drugs, but clearly having more is going to be helpful. And it also has good activity against genotype 3. It does promise a shorter treatment duration of 8 weeks in some patient populations, so it is an interesting combination. Here they looked at the interactions between Genvoya or Triomec, so really looking at two commonly prescribed integrase inhibitors And although there were increases or decreases in some of the respective levels of the corresponding agents, this all did not reach a range where people felt that dose adaptation would be recommended. So that appears to be good combination partners. There are interactions with HIV protease inhibitors, which will not be able to be combined, as well as efavirenz, which induces and reduces drug levels of the hepatitis C drugs, probably will not be.
So you'll be able to use a booster with this protease inhibitor.
Exactly. So not a PI, but with Genvoya seems to work very well. So if we summarize this hepatitis C parts, I think it's important that hepatitis C PCR for diagnosis of acute hepatitis C remains important, as antibodies can be still negative. There's obviously first country which really, with no restrictions anymore for who you treat, have a complete, very good uptake of DA therapy in acute and chronic hepatitis C, achieving 76% cure rate in their overall HIV positive MSM population, which has a direct impact and dramatically reduces the decrease or reduces new infections. Patients with co-infection, lower CD4 count, and cirrhosis show less favorable SVR rates, which means people really have to do fibrosis stage assessment and treat before cirrhosis occurs. This is the first conference which reports back on a very large cohort of patients with liver cancer. Doesn't seem to be an increased incidence of HCC with DA use. And with regard to the PK study I presented you, the new AbbVie combo seems to be combinable with two commonly used integrase inhibitors, boosted elvitegravir and dolutegravir. So I included some little aspects around hepatitis B. This is a long-term follow-up in patients with HIV and chronic hepatitis B who almost half started with a TDF containing regimen. All of the patients in the analysis in the end had TDF as part of their ARV as recommended by guidelines. And if you look at the mean follow-up, it's 107 months, tells you this is a very long follow-up. And I think the interesting thing here is that you have a surprisingly high seroconversion rate. So a lot of people lost their HBs antigen, and most of them then also developed anti-HBs. And remember, that's really what you want to achieve with long-term treatment under nucleoside therapy. That is very, very rare in mono-infected patients. And I think the story here is that if you have HIV and then get infected with hepatitis B, you have a higher risk of chronicity because your immune system can't get rid of hepatitis B. If you then start HIV therapy, have immune reconstitution, you enable that person, which probably would have been able to sort of clear infection, enable him to lose his hepatitis B antigen, which is important for many different aspects. It also means that we have to monitor that response over time because there is a higher likelihood of seroconversion. And then there was an interesting trial looking at TDF to prevent perinatal hepatitis B virus transmission. This is something which some guidelines at least recommend in mothers who have a very high viral load. So there have been clearly studies suggesting that if you have a high viral load of above 6 or 8 logs, you really remain at a risk of transmitting hepatitis B to the newborn, even in the setting of giving birth dose HPV vaccination and immunoglobulin. And this is a Thai study which compared placebo versus tenofovir administration after 28 weeks into pregnancy. And the infants got 4 vaccine doses, 5 at birth, and then months 1, 2, 4, and 6. So this is somewhat higher than some of the other vaccination schedules, plus HBIC at birth. And the interesting thing here was that the vertical transmission rate was very low in this intensified vaccine administration, only 2%. That's the lowest I think ever has been reported in a very large trial. And of note, those mothers who got tenofovir, there was no event recorded. So really suggesting that that could be a specific measure to prevent transmission in highly viremic pregnant women. And then moving to fatty liver disease, there really has been a shift for a lot of groups to work more on fatty liver disease. Brings us a little bit back to our little BMI discussion, which we don't really enjoy very much, BMI discussions these days, do we? In our own group, we looked at 344 mono-infected patients, and we do an annual FibroScan and measure liver fibrosis. And with the CAP measurement, we can also assess liver steatosis. And the interesting thing is that there is a significant proportion of patients with HIV without having increased alcohol intake, without having viral hepatitis, which end up with significant fibrosis of 10%. That has been discussed in many different ways. Is that attributable to direct infection of hepatic stellate cells from HIV? Is there inflammation of the liver, particularly if you have a long history of replication and low CD4 counts?
Past thymidine analog therapy and mitochondrial injury.
Yeah, so the interesting thing is that when we did our very first study, thymidine analogs were independently associated with that risk. But in the newer cohort analysis, this all disappears because there is no thymidine use anymore, which is impactful. So that was something which played a role in the past, but then the question always came, well, with the newer drugs, the lower mitochondrial toxicity, is this still going to play a role? But it really looks as even independent of thymidine analog use, you have a significant risk for fibrosis and even much higher risk for steatosis. And this is one of the first studies which now looks sort of, over the time follow-up. So this is now 2 years into measuring regularly. And you can see that there is a further increase in patients, particularly with regard to steatosis, and a lot of that relates to developing a diabetic state, which seems to have a negative impact. And I think one of the big questions in the room is, are we going to see more and more metabolic syndrome, more and more NASH? Obviously, NASH can only be diagnosed by liver biopsy, but that's something to keep in mind. And I think as patients are aging, I think just as we're seeing issues around other organ toxicities or diseases, the liver, I think, will also become a spot of interaction. And one of the only ways to treat NASH is actually weight reduction. So I think this whole aspects of weight reduction and also changes in the microbiome by weight reduction, I think actually may blend in here and may become a future treatment sort of target. And then with regard to antiviral therapy, there was a Spanish study which looked at changes in liver steatosis after switching patients from efavirenz to raltegravir, and this was a controlled study. So whereas the patients who remained in efavirenz, so that being the control group, there was a further increase, and there was a significant reduction in the raltegravir-treated patients, telling us that if we have someone with NASH, we may choose our HIV treatment wisely and accordingly, and can thereby minimize the risk of further steatosis development. So in summary, hepatitis B seroconversion is more frequent in HIV co-infection. That has some implications for monitoring. For perinatal transmission, it looks as if we give very frequent vaccination with HPIC, we can really lower rates to 2%. Obviously, tenofovir in highly viremic exposed mothers can help us to prevent transmission. TDF, so that will help to further reduce perinatal transmission, and then significant fibrosis and steatosis are found frequently among HIV patients. I think we still have to learn what that all will mean, but I think wise choices with ARV can help us to not have too much hepatic steatosis.
Brilliant.
There were a couple of presentations on increases in cholesterol after SVR in individuals with hepatitis C infection, and I must admit I've never noticed that in my patients. I probably haven't been looking carefully enough.
Yeah, but that's a hallmark of hepatitis C, that there's an interaction with LDL, and indeed that is something to know, that there are changes in lipid metabolism after obtaining SVR.
Any other comments, gentlemen? Well, thank you for a wonderful discussion, as always. Thank you for participating. Give us your feedback. We'd love to hear from you. Tell us how we can make this a better program, if that's possible.
It is.
And we'll see you the next time. Thank you.
This concludes our web symposium entitled ARV Therapies and Therapeutic Strategies, CROI 2017 Expert Review, which has been brought to you from Seattle, Washington. This program was produced by the Postgraduate Institute for Medicine and Viral Ed Inc. This coverage is not sanctioned by the conference organizers and is not an official part of the conference proceedings. To receive CME credit for completing this activity, please follow the on-screen instructions or go to www.viraled.com/CROI 2017/conference review for more information. For more CME programming on CROI 2017, including an on-demand version of this symposium, a comprehensive expert review and discussion on key presentations, an audio podcast of key points from the conference, and a post-conference CME dinner program series, please visit www.viroed.com. Thank you for your participation.